I'm Dr. Dohn, formerly head of the neurosurgical department at the Cleveland Clinic, Cleveland. And I have the great honor and pleasure of being able to have a chat and an interview with my old friend and my old chief, and at one time my old professor of neurosurgery, dating way back, Dr. Wally Hamby. And we're fortunate to be here at the new facilities of Cleveland Clinic, Florida, where Wally is retired and has been so for a number of years, and where the Cleveland Clinic is building a new Cleveland Clinic, Florida. And we're in the interim facility in Fort Lauderdale, Florida. The reason behind this interview is a couple-fold. First of all, I think it's a great opportunity to have a touch of the old clinic here in Florida that we can amalgamate with the effort that the clinic is doing here in this part of the country. But also, it gives a chance to contribute something to the archives of the clinic, but also the archives of the American Association of Neurological Surgeons, formerly known as the Cushing Society. Wally, I'm sure, was, if not one of the founding members, one of the young Turks who came into it shortly thereafter. The AANS, as it's known as, has a national office now and is established in archives. And they're collecting videotapes of some of the master neurosurgeons from the past, so that we'll have this for a record. Also, I was pleased to know that the Cleveland Clinic has its own archives now, and I think this will be an invaluable contribution for that, to hear something of the early days of the clinic. For Wally was the first neurosurgical resident at the Cleveland Clinic. And so I thought it would be appropriate to trace something of Dr. Hamby's career, both at the clinic and subsequently in Buffalo, something of the interrelationship with Dr. Hamby and with the founders whom he knew and some other colleagues who have gone on to careers at the clinic and otherwise, and also his experience in Buffalo where he went and had a career, and finally when he returned to the clinic as chief of neurosurgery succeeding Dr. Gardner. Wally, is that going to be too big a platter for you today?
I have a great feeling of affection for the clinic and for neurosurgery, and it's a great pleasure and an honor for me to have been invited to come back and talk with you about these things, and so I'll be happy to talk about anything along that line that you think might be interesting.
Well, first of all, I think it would be important to know something of your background, where you came from, and something of your earlier education. What happened to you before you finally ended up heading toward neurosurgery?
Well, to start off, like so many other people do, I was born in Ennis, Texas, on August 2nd, 1903. My father was a mechanic in a network of southern cottonseed oil mills. And he went out to Ennis from Cobb County, Georgia, where he had been born, and married my mother. And then we went through a series of migrations, finally wound up back in Sylvester, Georgia, where I went through high school, and went through a couple of years at Mercer University for pre-medical training. While I was there in South Georgia, the boll weevil came in and destroyed the cotton economy of the South, and it was a tremendously difficult time. After my father died, my mother went back to Oklahoma, where she had acquired a little property, and that led me to going to the University of Oklahoma for medicine. And I graduated there in 1928. I had been strapped financially, getting there, and so I took a couple of years out to follow a service as assistant in the Department of Histology and Embryology. And
was that at Oklahoma?
Yes, at Norman, Oklahoma.
Oh, yeah. At the undergraduate school.
In the undergraduate part of medical school. And this gave me a great deal of interest in the nervous system, and which I unconsciously carried along with me. So finishing there in 1928, I found it expedient to go to Buffalo, New York, for my internship. It wasn't my particular choice because I didn't have a great deal of love for cold weather, but among other things, I got a salary of $40 a month. And after I got, most internships at that time didn't give you any salary at all. You got your board.
All you could eat.
All you could eat, place to sleep, and your laundry. Well, when I got there, though, I found out that that the $40 required the expenditure of 25 of them for a room rent, because they didn't have rooms for the interns. Well, anyway, I got along pretty well on the $15 extra that I could spend foolishly every month. That's when I got interested in primarily in surgery. I had always been a good hand worker, and I had done modeling of anatomical parts while I was in my years at Oklahoma University, and also in sketching and drawing, which I had part of my income while I was in medical school from that. The service at Buffalo was purely a routine general medical internship that didn't interest me a great deal, except that it focused my interest on surgery instead of medical.
That was
science.
At the Meyer Memorial?
Yes. Well,
it wasn't called that.
Then it was the Buffalo City Hospital. Yeah. So through the interest of Dr. Herbert Smith, primarily in Buffalo, I applied to the Cleveland Clinic, where Dr. Cryle was a world-famous goiter surgeon and had a tremendous reputation, and was accepted. And so I finished my internship and went off down to Atlanta to visit my uncle and a young lady with whom I was greatly enamored, and a telegram came. No, I'm getting ahead of myself a little bit. In May, I think it was May 15, the stored X-ray film at the clinic exploded and killed 125 patients and personnel.
The infamous Cleveland Clinic disaster.
That's right. And included among these was Dr. Ted Locke, and his resident, Hunter Sheldon. Oh, wait a minute.
His last name was Hunter. Right?
His last name was Hunter.
Yeah.
And So that wiped out the neurosurgical department. Well, as I was talking about this telegram coming, it came down to Atlanta telling me that they would like me to come immediately to as soon as I could to the clinic. And I'd been planning to spend another week or two there, but my uncle intercepted my reply, and so I changed it around so that I wound up at the clinic the next morning. The clinic then was, the old building was closed. The hospital was still working. The clinic facilities were scattered all up and down Euclid Avenue in a series of donated or loaned old mansions and a girls' school. So everything was very haphazard, but oddly as it might seem, the clinic either enjoyed or suffered its highest registration in the rest of that year that they had ever had. Gave them notoriety, I suppose. But I went on to the general surgical service then, and had services under Dr. Cryle, Dr. Lauer, the orthopedist, and finally under Dr. Gardner for the last 3 months.
Dixon? Was Dixon the chief
Yes.
of orthopedics?
No, he wasn't.
It was his predecessor.
It
right?
was his predecessor, and his name escapes me just at the moment. He was a little lame and very nice man, but his name just gets out of my mind. But am I doing all right?
You're doing good. Let me ask you, I've heard that those were tough times financially for the clinic, and also, as you say, with the organization. Did they put you right to work? And
oh yes.
How did you had to go and visit all those other scattered around places, or how did you do your work then?
Well, as you know, when a fellow first comes in there, he spends part of his time in the clinic itself and part of his time in the hospital, and they don't or didn't then interrelate. So we lived outside and served the clinic, going to the different places to interview patients and examine patients and so on. And then when the patient went to the hospital and we went on to hospital service, we lived in a rented apartment somewhere, and went into the hospital and spent our time. And on special services like neurosurgery or general surgery or whatever, the senior resident lived in the hospital while his assistants would come and go, and that was the way they functioned. And you mentioning the financial difficulties that they had, if I'm not mistaken, and this is purely the type of recollection that you have, I believe that there were a tremendous number of suits against the clinic by the patient's relatives, and if I'm not mistaken, the whole thing was finally settled for something like $1 million. Nowadays, I suppose every one of them would want $10 million. But anyway,
how did you spend your first time? You say you worked with Cryle. How long did you stay in general surgery, and what led you into neurosurgery?
Well, there was no neurosurgery when I first went there, Locke and Hunter having been killed. But so I was on general surgery, and because I had elected that side instead of medicine, and so I served with Cryle and with Lauer and orthopedics, and then finally with Gardner. But we lived outside, but the senior on the service where we were attached lived inside, and we would spend 3 to 6 months on a service, and then that would take, the whole thing then would amount to 2 years. By that, at the end of that time, we were certified, in my case, as for general surgery. Dr. Cryle was the outstanding general surgeon then, and he was a most ingenious man. He had, he was able to take on anywhere from 3 or 4 to I think something like 16 was the greatest number of goiters that I remember him ever doing. I don't know whether it is a record or not. But he had, of course, the operating rooms couldn't handle those things. So he devised a method by which he would operate in the patient's room. And this was before the hyperthyroidism was as well protected. Hyperthyroid patients were as well protected as they are now. And so they developed a ingenious method of, quote, stealing the thyroid from the patient. The anesthetists come in and give the patient a few whiffs of oxygen with an encouragement. Next day she'd add a little nitrous oxide to it, and before she knew it, she woke up with a bandage around her neck because the thing had been sneaked in on her, and the operation's all done in the room.
Weren't they were fearful of the thyroid storm.
That's right.
Isn't that?
That was a great storm of hyperthyroidism that would occur with psychic trauma and things of that sort. So, of course, iodine had been introduced by that time to help control this part of the thyroid problem. But and so the patients were, the hyperthyroid patients were all treated this way up to a point of maximum benefit that they could get from it, and then the thyroids were taken out. And Dr. Cryle was a master technician, and he would take out the gland in 15 minutes, and people, all disbelievers, would doubt that, until they found out one team of residents was opening a neck in one room while he was taking the thyroid out of an opened neck in the next room, and then he went to the next room while the residents closed this patient's neck, and then he went back to the first patient. And so it was, his 15 minutes was just the 15 minutes required to take out the gland itself. The rest of it took another 15 minutes probably for each stage. But this type of the mechanisms and intrigued me because I'm a hand worker, and I always enjoyed that type of thing. And so there was no particular aim about neurosurgery or anything of the sort until Dr. Gardner came in. And he came in 29. No, it wasn't.
Must have been just after, I think it was, as I recall, it was near the end of 29.
End of 29, that's right. And he had a surgical resident assigned to help him out. And about the third second or third one was me. And this occurred at the end of that training program, which ended in July. So I put in my 3 months of neurosurgery there. And then the powers that be gave Dr. Gardner the privilege of having an exclusive neurosurgeon, neurosurgical resident. So I became first resident. And
that would be in?
Be in 1931.
31? Yes.
Yes, that'd be 31. I'd finished my 2 years in general surgery.
Tell us some of your recollections of Dr. Gardner.
Dr. Gardner was a small, energetic, friendly man who had served under Dr. Fraser in Philadelphia. At that time, neurosurgery was such a hazardous and complicated discipline that it developed a very peculiar persona of the surgeons who did it. The charting of virgin territory is always rather traumatic, and these people responded to trauma with sometimes physical, but a great deal of emotional violence.
What you mean is they were all mean.
They were a hard bunch of people to live with. And Dr. Gardner and Dr. Fraser was of that type. And Dr. Gardner decided that whatever he did, he was not going to grow up to be that kind of a person. And he was eminently successful. I don't recall him ever embarrassing or humiliating me for any of my many transgressions. He tried to make these things learning experiences. I recall once he handed me a removed skull flap to rongeur some rough edges away from it while he finished his closure of a wound. And suddenly I realized that it wasn't in my hands anymore. And I looked down, and there it was on the bloody floor. Dr. Gardner glanced at it and said, well, you know, I've always wondered whether a boiled bone flap would be accepted. I said, take it out and put it in the boiler. Let's see. So the nurse, after a while, brought it back. We put it in place. It was accepted. This was a typical approach of his to a problem.
What was the difference in your ages?
5 years.
Oh.
He was 5 years older than I. See, he had just finished, and I was in the beginning of mine, so there's just about a 5-year difference in our experiences.
Did he put together the program that you were going to have, or I know it wasn't as organized as it is now, or did you do that, or how did that come about?
We didn't have a program, actually. Dr. Gardner had a little bit of laboratory training when he was working in Philadelphia. I remember one time he had an exhibit showing his experiences with putting a drain into the spinal canal and running the fluid pressures on a chymograph, an old smoke drum chymograph, for 24 hours, I believe it was, recording the volume and the changes that went on in time. And so this was an experimental thing that he did, and one of his associate junior members of the staff stole it from him and read the paper in his own name at a national meeting. So politicians weren't the only people that do this sort of thing.
He told me of that also. He never forgave that.
No, he never did. But anyway, we did the things that arose in the requirements of surgery. And of course, in those days, these were so primitive that we invented a whole lot of things that were that came into common usage. One thing that we did was to he'd go to a meeting and hear something that seemed unusual to him, come back, we'd try it out. If we liked it, we'd keep it. If we didn't like it, that would be the end of it. One time he told me, he came back from a meeting and said that Dr. Max Pete over at Ann Arbor had developed a way of taking care of a person with trigeminal neuralgia, operating on him in 15 minutes. Well, we took about an hour for the operation, and our job was well done, and we were quite pleased with it. But he was intrigued by what Dr. Pete could be doing that he wasn't doing. So he sent me over to see him. And Dr. Pete gave us, welcomed me very heartily, and Dr. Eddie Kahn, who was his assistant. And so we went in to see him work. The first patient was a lady who, Dr. Pete was a big, bluff, hearty, kind of a friendly man, and he was injecting Novocaine into the scalp and talking to the patient, and she had had little narcotics but no real anesthetic. And so then he incised the skin and opened the muscles and took a piece of a temporal bone out and lifted the dura and closed the middle meningeal artery and lifted up the dura and exposed the sensory root of the ganglion and flicked off the little nerve rootlets one by one until they were all gone except the first division was intact and the motor root hadn't been bothered. That was one of the things that so many people, neurosurgeons of that time, were doing. They were destroying the motor root, and it made the patient have paralysis of chewing on that side. Well, anyway, I was watching the clock, and it ran 14 minutes. He came out then and closed up very quickly and put a dressing on it. The clock said 14 minutes. So another patient was waiting in the other room. We went in there, and he talked to her and went through the same procedure. And this was 15 minutes. So as she was being taken out of the chair, she implored Dr. Pete to do the other side of her face. She was one of these rare cases of bilateral tic. So he agreed, and so he went back to operate on the third patient, and while they turned this second patient around in her chair and fixed up that operating room. So then he came back and did the second side of the second patient, making 4 in one morning, and the time was 2 hours and a half. And we, as I said, we spent an hour on a case. So Dr. Kahn said, well, I told you, we don't do anything that you don't do. We simply don't waste any time. So when I got back and told the boss about it, the first patient that came in with a tic, I operated, and he assisted, and our time was 15 minutes. And that was our routine from then on. So it was things of this character that worked into our techniques and our routines.
What was the most common problem that you operated on during your training? You weren't doing any discs then?
No. Well, there were tics and brain tumors and spinal cord tumors.
You didn't do trauma very much there?
Spinal canal tumors. No, we didn't get much trauma at the clinic. And as a matter of fact, I didn't get an awful lot of it in Buffalo because I never, it wasn't a thing that interested me particularly. It was a deadly and dangerous thing. At that time, a patient who couldn't survive an ambulance ride certainly had no chance of surviving a neurosurgical operation. So the general surgeons, who were the equivalent of modern traumatic surgeons, did most of that. And so if there was an indication for neurosurgery, we'd be called in on it, but we didn't do much. We didn't have much traumatic surgery.
As part of your training, did you go somewhere else to train, or did you spend all your time there?
No. One of the things that was of great interest at that period was the classification of gliomas, the cancers of the brain, as it were. And they were variously classified by general pathologists in a way that didn't distinguish between the different types. And Dr. Percival Bailey, who was Cushing's pathologist, had worked out a classification that essentially is what we have now. But I found out that our classification didn't allow us to really investigate cause or effect of different therapies, and so I wanted to start a laboratory and classify our own tumors. And so they gave me a laboratory in the new research building, and where I shared quarters with some lions and tigers and things of that type.
Dr. Krause?
that Dr. Krause had brought back from Africa to in his work on the relationship between various types of animal life and the effects of their endocrine glands. And so it was quite interesting. I'd be over there at night working along in the laboratory, and all of a sudden you hear, a lion was out in the elevator where they stored some of these specimens before they were sacrificed. But anyway, they gave me a laboratory, and so I went to work trying to duplicate the work that, or the specimens that Bailey had used to classify his gliomas. And I had a horrible mess. I couldn't make them work out well. So Dr. Gardner sent me over to University of Chicago to work with Bailey for 6 months. I got over there, and the first thing I found out about technique was that in doing the silver and gold stains, they'd come out with precipitate all over the slides. And nobody had ever told me that you had to have chemically clean glassware. And so the first thing I found was that there was a big pot of sulfuric acid with a pile of another chemical that you use to make up a cleaning solution. I've forgotten it right at the moment. But every piece of glassware, everything that touched a slide went through this cleansing process. And so when I got back, it was easy to make my laboratory specimens worthwhile. And so we classified our pathologic material and wrote some papers about it. And in my senior year, last year there, I got all of our brain tumors classified and fixed up an exhibit of it that was taken to the American Medical Association. And that was my first experience with scientific exhibits. That was one of Dr. Gardner's hobbies, and he told me later that toward the end of his career that he had set up and explained, monitored more exhibits at national meetings than any other physician had done. And I can well believe it.
What about A.T. Bunce? He was there too, eh?
Dr. Bunce, before Dr. Gardner was brought to the clinic, Dr. Bunce was the son of one of the founders of the clinic, and he had just finished his general surgical fellowship, and so he went to the Mayo Clinic to get a year of training in neurological surgery, thinking to come back and head the department.
This was after the disaster.
After the disaster. Yeah. And so, but in Dr. Cryle and Lauer went over somewhere in Pennsylvania, I think it was Meadville, to attend a local medical meeting, and they heard Dr. Gardner talk on some neurosurgical subject. I can't remember what it was, but they were so impressed with him that they had him come on back to Cleveland with them instead of returning to Philadelphia, and he was offered the job, and he took it, and so that's how he got to the clinic. And so then, by the time Dr. Bunce had finished his 6 months at the clinic, at Mayo Clinic, he came back to the Cleveland Clinic and became Dr. Gardner's associate.
So then, off to Buffalo after that, eh? That would be in 1933?
Let's see, 34.
34.
34. I finished my service with Dr. Gardner and had quite a time trying to figure out where to go practice. I never liked the city of Buffalo. It's cold and it's nasty and it's cloudy.
And it snows.
It snows. All the precipitation has to be shoveled. So I didn't like Buffalo, but at that time it was considered necessary for a neurosurgeon to have a clientele of 1 million people or near that to be able to make a living. And so I wanted to get into a city with a medical school, and one that didn't already have a neurosurgeon in it. The only two that I could find was Milwaukee and Buffalo. I had an entree to Milwaukee through medical fraternity, and he was dean of the medical school at Marquette. And so he was quite interested in me coming there, but he checked the situation over for about a couple of months. And then he got back in touch with me and told me, you better go ahead and take Buffalo, because there's a school and town clash in this city between the medical school and the city. And so you get on one side and the other one's alienated, or vice versa. And
that hasn't changed much in the world, has it?
No. And so they had one neurosurgeon in each one of those places. So Buffalo didn't have a neurosurgeon, so I went there.
So you pioneered neurosurgery
Mm-hmm.
there, and as I recall, you were also the professor of neurology, weren't you?
Well, yes, that came on later. Buffalo, or starting up a new service as complicated as this is a trying situation. When I went in with the cooperation of and welcome of the local profession, the medical school, and all the hospitals in town. As a matter of fact, it was difficult to concentrate your work in one hospital because everybody wanted to have a neurosurgeon on their staff. So anyway, it finally worked out to where the Buffalo General and the Mildred Fillmore and the City Hospital, which is later the Meyer Memorial Hospital, became my chief working places. But it was interesting. We had to, we bought the basic tools that we needed. We had to practically build every piece of equipment that that wasn't standard down in the shops, and of course there was no trained help. I remember the first operation I did at the city hospital, leaving orders that the patient was to have blood pressure taken every 15 minutes for 2 hours, then every 4 hours for so many hours, and then daily or twice a day or something of the sort. And the nurses calling the intern quarters and rousing up an intern to come up and take the blood pressure every 15 minutes. Well, the first morning I got there was chaos because the nurses weren't allowed. They didn't know how to, and they weren't allowed to try to take blood pressures. So that's one little thing. Would never have occurred to anybody. But these things gradually were worked out. And
what kind of anesthesia was there?
well, they had at the clinic. They had nitrous oxide and oxygen and ether were the main standbys for surgical, general surgical work, but they aren't applicable easily to neurosurgery. So Dr. Gardner started using Avertin, which was a messy concoction of several different narcotics in some kind of a liquid base, and this was injected rectally, and it was messy, and it was unpredictable really in its effect. But we didn't have any intubation and assisted respiration and things of that character that came along after the war.
You operated your patients, as Gardner did, in a seated position?
Yes. That is for
certain conditions.
For yes, the things, operations where access to the head was difficult in the horizontal position. That is, when we operated on the back of the head and on the temporal regions, this was easier, and we thought more effective by doing it in the back of the cervical spine. Doing it in the sitting position than in horizontal.
Tell me how, in those days, you kept up. Now we have continuing medical education and so many different societies that we can go to keep up. Can hardly keep up with going to them all. What did you do in those days when there were so few of you?
Well, I remember one time going to a meeting of the Harvey Cushing Society, which just after I had got to Buffalo, and this was held in New Haven, and Dr. Cushing was there. The meeting was one of a group of men who had trained with Cushing, and so the general neurosurgeons were not invited, and there were none of these paid admission things in those days. When somebody had a meeting, he stood the expense of it himself or shared it among his friends, and nobody ever paid any fee for going to somebody's meeting. All he needed was an invitation. Well, anyway, I remember going to this meeting, and we had such a good time that Helen and I decided we'd just, on the last day, we'd have a little meeting up in our room, and so we called up the bar and had a bartender come up. We turned the beds around so that the two beds lay side by side against the wall, and this opened up our room so that the bar was over on one side, and somebody remarked after it was all over and these people had stopped going through, that here you've had 90% of the neurosurgical expertise, the proponents of 90% of the neurosurgery in the country, all housed in an $8 hotel room. In the Hotel Taft.
It would be like a reception with people coming.
Yeah, we'd pass the word out, we're going to have a drink up there, come up and get one. So all these people came up. Well, the Harvey Cushing Society, the Society of Neurological Surgeons had already been established. I don't have the date at hand right now, but it was before 1928 anyway, and there were something like 15 men who were devoting their time exclusively to neurosurgery. They had started out as general surgeons, and then they had got some training one place and another. And so then when Cushing's graduates began to get together, they would go back to New Haven for nice meetings, and then they established their own society, the Harvey Cushing Society. And it wasn't until about 1930, somewhere in there, that they began to allow outsiders to become members of the Cushing Society. And that was then the forerunner of the Neurosurgical Association.
AANS.
The AANS.
Yeah.
And so the rest of us, those of us who were not Cushing's graduates and were not professors in medical schools and things of that sort, had no real home place to go for training, except when we were specifically invited to attend. And of course, we put out a few little suggestions now and then, so that members would invite us, and so we got to go to those meetings. But one time during the winter, it was cold and dreary, and Bill Beswick and I were feeling the need of a little refreshment. So we sent a farm letter around to people who could get to Buffalo in an overnight train ride. And I think there was something like 20 fellows came in. We sent them a proposed menu. We would discuss 4 topics, and we assigned a floor leader for each one of the discussions, and we'd have 2 in the morning and 2 in the afternoon. And so this type of meeting became so popular that after the war was over, it was really constituted or elaborated as the Interurban Neurosurgical Society. And Adrian Verbruggen
Was Paul Busey involved in it?
No, he wasn't. He was one of the Cushing group. Chicago boy who was a big friend of Verbruggen's. Anyway, they really made a society out of our first little attempt. But that was one place we would go. Then we would go spontaneously to any selected place we wanted to. We'd write the person and say, I'd like to come over and see you work. When will it be comfortable? And so I can remember going to Boston and to New York, Baltimore, and having some great experiences with some wonderful people that way.
Did you see Dandy work?
Yes, I saw Dandy work, and he was a great character, and for whom I had a great deal of respect.
Was Fraser still working after that? He was
Fraser,
gone.
no, Fraser wasn't working then.
And
I never saw him work.
what about Cushing? Did you see Cushing work?
I only saw Cushing one time in his operating room, and he was some patient's wound had been disrupted some way or other, and he was in a foul mood that morning, and so
he was the other brand of neurosurgeon.
Oh yes, and so somebody tactfully suggested that we leave the operating room and leave his residents to their fate while he finished up. That was the only time that I ever saw him work, but I had the pleasure of hearing him talk on several occasions when we went to different meetings.
So now, you had your own training program in Buffalo.
Well, our training program was one that simply grew out of expansion of the clinic program. We, at first we had no resident. The general surgical residents helped out in the operating room. It wasn't until just before World War II that we were given our first resident, and Dr. Frank Kane, and he went off to war and switched into psychiatry while he was over there, and went on to into that discipline instead of neurosurgery after the war was over. But Dr. Carl Graff came on. Oh no, Frank. Yes, Dr. Carl Graff followed Dr. Kane, and he became my first full-time resident. And we did very much the same type of training that I had received in Cleveland, and sending the boys to off to get neuropathology until our neuropathology department got to giving them a good training also. And they spent time in the Children's Hospital in childhood neurology and neurosurgery. We spent a great deal more time and paid more attention to neurology, I believe, then than is customary now. The majority of our diagnoses were made clinically, and they were spinal obstructing lesions could be verified, localized by fluoroscopy and lipiodol that was injected. Air studies by spine and by ventriculography had been brought to the clinic by Dr. Gardner, and that was used. Then we got interested in vascular lesions of the brain. You asked me about a nun who had an arteriovenous fistula in the cavernous sinus while we were at Cleveland, and she had her internal carotid artery tied off in her neck, and the bruit continued, and so Dr. Gardner reasoned that the bruit was, or the fistula was being fed from the other side across the midline, and that you'd have to cut off the carotid artery above the fistula to stop it. Well, that's what he did, and I think that was the first time that this operation had been done.
The intracranial occlusion.
Intracranial occlusion of the internal carotid artery, and well, it was successful. You know, this happens so frequently, not only in neurosurgery but everywhere. You do something and you get a beautiful result. Then you start applying the same technique to the whole train of them, and then you find out that there are all types of variations. And so
Not always successful.
And they aren't always successful. I remember one professor of neurology in Buffalo. His wife had a fistula, and that poor woman went through. She had already had the carotid tied off in the neck before I got there, and so I thought, well, I'll clip off this artery above the fistula and close it off. So we did that. It didn't work. Then we tried getting the other possible feeders into the cavernous portion of the internal carotid, and so we did several operations on the poor soul and never did get her fistula stopped. And but anyway, this first thing gave me a primary interest in the vascular intracranial system. And so, as a matter of fact, I wrote a book on the subject back in about 1950. And if you want,
it was the Bible.
Yeah, and well, you know, there were only 1,200 copies of it printed, and so when you think about the number of neurosurgeons there are nowadays, it'd be very unusual for one of them to have ever seen the thing. But if you ever get a chance to read it, or just look it over, I would suggest that you do it, because it really gives you an idea about how primitive you can be and still think that you've done something that is up to the minute.
It was up to the minute then, at that time. Huh? Yeah.
But I look through that and see diagrams of how you can build a machine that will allow the X-ray person to take a rapid series of X-ray pictures. We didn't have any machinery to do that then.
You had one of the first angiographers, didn't you? That Burton Bean?
Yes.
Yeah.
Yes,
It was unusual in those days to have an angiographer.
Yes, it was, and we sent him over to Stockholm to get trained by a Leverkrona's group over there. And the trouble with that was, though, that in this era, we couldn't trust, or not, I don't mean trust, but we couldn't allow another person to do a job on a patient that might result in damage to him when he was our responsibility. So in other words, we couldn't delegate the responsibility of a radiologist injecting things into a person's system when it was our responsibility. So we had to do the injections and have the x-ray people make the pictures, and this finally got around to the point where they could do them, and the techniques got so complicated that the surgical residents couldn't get the experience that would give us the optimum results. So that's the way neuroradiology was born.
So how did you eventually return home to the mother house, so to speak, back to the Cleveland Clinic?
Well, as I said, Dr. Gardner was always my boss and my best professional friend. So he had anticipated. He had brought a young Dane over to his service, who had finished working with Bush in Copenhagen, and they thought that Tarnoy would follow him, would be his successor. But it turned out that Tarnoy spent his, I guess he was there 5 or 6 years, and but then he decided that he wanted his children to grow up to be Danes instead of American citizens, and he went back to Copenhagen. And so you weren't quite ready to take on the job by the time the boss retired. So he asked me, why don't you come on over here and spend your last years, 8 years, and take over the job when I'm gone. So I did. And it was a very happy arrangement for me. I never regretted one moment of it. And so there...
Nor did we over there.
Oh, thank you. But it was good to get back to the old home base and see all of the changes that had occurred. And so those were very happy years for me, and I look back on them that way.
Some of the experiences that you've had and your special interests and your contributions, which you may not like to admit to because you might feel like you're boasting, but I think those things would be of interest to people, and those are the sort of things that we maybe should talk about a little bit. Some things that you, over your career, were particularly interested in. You've mentioned your interest in vascular lesions, and certainly when you came back to the clinic, it was understood, as you and I have talked about, that those things were going to filter down to you, and yet you've had a number of important contributions like that. I wonder if you could just share some of your thoughts about that.
Well, I doubt that I ever made any very great contributions. I suppose the surgery of intracranial aneurysms was the one that was most important.
Maybe the intracranial surgery of intracranial aneurysms.
Yes.
It might be something I would say was certainly one of your contributions, because prior to that time, and even during that time, people were tying off the carotid in the neck, or not really going at the aneurysm to clip them off.
Yes, well, you know, Walter Dandy, had a patient one time that had eye muscle problems and some sensory changes around his face that let Dr. Dandy suspect that the patient had a little tumor at alongside of the cavernous sinus that was producing these things. So he explored the area and he found a little aneurysm sticking up there, making pressure on these nerves, and so he put a silver clip across the neck of it. And I think that was the first recognized intracranial case. I went down to see him one time, and he said, you know, let me see, how was it said? Oh, he said he had done this thing, and then he thought that he had been the first one to occlude the intracranial carotid artery until Gardner's paper came out telling about the one that I mentioned. And so he said, you beat me to one there. So, well, you know, that sort of thing gives you such a stimulus that you try to go on with it further and further. And so then I remember that Cushing's, in his book about the arteriovenous aneurysms of the brain, he said, I can't quote him precisely, but something to the effect that surely this venomous looking lesion will never be attacked surgically. Yeah. And well, this with the various things that developed, we could attack them surgically. And I remember one of the highlights of my service was going down to a meeting of the Congress of Neurosurgery in Chicago, and operating on a nice young Italian mother who had an arteriovenous aneurysm down deep in the Sylvian fossa, on the Sylvian fissure on the right side of her brain. And this was a case where we were set up like you people are. They were doing the video of it.
Live video.
Live video in the operating room, and then the sound was being transferred over to the hotel where the meeting was going on, and so we were able to get down and get this. I took my surgical nurse over with me from the clinic. She had a great time, and we had a panel of discussers up there, and so they made a great to-do about this, about her, and well, we got the thing closed off and got her out and got her downstairs. They got her downstairs. I went in, changed clothes, went down and talked with the family, and they were very, very, very appreciative. And then I walked down to, I looked around for the fellow who was supposed to have been my bird dog while I was over there. He wasn't around. There was nobody around. There was a fellow sitting at the desk down on street level. He didn't know from anything. I said, well, how can I get a cab? He says, cabs don't come into this part of town. He says, people get killed down here. So I was supposed to be at dinner by this time. So I went out on the street and finally flagged a cab down and got back to the hotel, too late for dinner. And so Mary Jane and I had some room service dinner up in the room, and some of the local boys says, "My God, you don't mean to say you went out on the street by yourself?" Well, anyway,
that was a very memorable occasion. In fact, one of our old fellows and I were just talking about that. And there was a time during the case when it became very red, and you didn't do much talking for a little while, and then suddenly it was that was it. It was out. But I always remember that.
Yeah, I remember I forgot who the moderator was now, but he said, well, now, this wound was full of blood, and we were trying to get it out so that we could get down and put a clip on the bleeding point. And so he said, let's talk about something else now, and take the camera off of Dr. Hamby and let him work it out for himself. And so I could hear the boys answering back, "Oh, no, let's see how
what he gets.
Let's see how he gets out of this."
Well, Wally, obviously you're not still working. When was it that you retired?
Well, in 1968, that was in 1963, Dr. Gardner retired, and so I came on there and just essentially continued the line of work that you all were doing, and you were getting primarily interested in stereotaxic operations. Wallace was working, he was getting specially interested in the spine. We were all doing general neurosurgery. We had and our training program was very, I thought was very attractive at that time. But then along in 1968, my time was up. We had a statutory retirement age of 65. And so I came down here and found that it isn't easy to become a consultant. I had the opportunity. As a matter of fact, one man even had a big brass plate made for put on his front door of his office with me listed as a consultant. But you know, I suppose that I probably was a better technician than I ever was a brainy type of neurosurgeon.
You were a doer rather than a talker?
Yeah, I guess so. But anyway, when it comes around to advising someone, I could advise him according to what I would do in this case. But I couldn't take the responsibility of telling him to do so-and-so and then seeing how he did it, and I knew it wasn't going to work. So for that reason, I never went into any advisory or consultant capacity. And so I simply dropped it off and came down, and I thought, well, now I've got a beautiful club over here less than a mile from my house, and I've got the ocean over at less than a mile from my house in the other direction. And so I'll learn to be a good golfer. So I went, I started working on my golf, and I found out now that that after, let's see, about 18 years, I guess it is, or 19.
Getting close to 20.
Getting
Next
close
year,
to
huh?
20, yep. Yeah. I score about 5 strokes more than I did when I started learning how to be a good golfer.
And how many times a week do you play?
Oh, I play 3 times a week, play with Ellie on one day, and then after November, we play on Mondays. During the summertime, we don't. But I play 3 or 4 days a week.
You had other interests. I used to admire you for that, to occupy your mind, and you became quite an expert on parade, as I recall.
Oh yeah.
How did that come about?
Well, when I was a medical student, we had a very nice urologist that became interested in us, and so he would invite a few of us over to his house, maybe 3 or 4, over to his house to eat some hot dogs and a bottle of near beer. This was back Prohibition times. And he would give us a little synopsis or a little item to read up on and write a little paper on it. And so he gave
present at that.
and then we'd read them to one another. And so he gave me the name of Ambroise Paré, and the old French 15th century surgeon, or he was actually a charlatan surgeon, who became the father of modern surgery. And so I put the little paper away, and after a while I found another paper about him, and so I cut that out and stuck it in my file. As time went on, I accumulated quite a volume about Ambroise Paré. And then I got to go into Europe to medical meetings, and I'd rent a car and I'd drive around. He was a military surgeon, and so gradually I worked out a map of all of his voyages, as he called them, that he went to various places with the armies, and the patients that he treated and so on. And so this all worked up into a mess that one of the best French articles or books about him had so much information on it that I translated that into English. And I think I wrote something like 3 books about him. This was one hobby. Then I've always been interested in painting. I have painted some atrocious looking pictures, and caricature sculpture, and wood carvings. My latest thing along that line is making models of old ships, the old tall ships. And so I've made about 30 of those since I've been here. I'll make one at the drop of a hat to anybody who happens to want one, because the house is full of them. I can't find any place to store them anymore.
So as you say, you're a hand worker.
Yeah. Well, that's one reason that I'm not good at golf, because I never had any bodily coordination, but I did have with my hands, and so that still gives me something to do.
Well, we used to admire your handwork at the operating table. Let me tell you, when you told about Max Pete, I think the residents, when you came to the clinic, used to stand in awe of how easy you made difficult things look. So do you regret retiring and getting out of the medical field?
No, I don't. I've enjoyed it. I've enjoyed every bit of it, through hard times and easy times and good times. But it's a different field than the one I was in, and I don't think that I would enjoy working it now, especially the way people do, like they do here in Fort Lauderdale. For instance, 2 associates will do very complicated neurosurgery, and they do it beautifully. And I was never used to that. I always had people waiting on me, and I'll put this thing over there, you hold it, you know. Well, nowadays, there isn't anybody over there to hold it. You've got to find some other way to take care of that situation. And this is something I wouldn't like to practice neurosurgery that way.
You had your time.
I had my time.
Well, we're really, we're most appreciative, Wally, of you taking the time out today to do this. One fortunate thing is that the club has not started to have Monday golf yet. Isn't that true? And besides, there's a hurricane going through here, so I think at least we didn't take you away from your golf game today.
Thank you, Don.
Well, thank you very much.